Good afternoon. I almost said good morning. It's the afternoon. Happy Tuesday, everybody. Hope you're all doing well. Welcome to March's Better Breathers Club. Exciting. We have two presenters today. So wanted to get started on time. So we have time for everybody to both of our presenters to share their information. Time for us to ask our questions, but we'll start off as we do with introductions. So if you want to share your name, if you want to share what brings you here, I will kick us off. I am Jessica Jones. You know what? A lot of you asked me last month if I work here. I do not. I am just a patient too, helping to facilitate Better Breathers Club. And so that's my role. I have chronic asthma, been a patient here for, I don't know, maybe like 5 years. I was one of those people they think had COVID before they were calling it COVID. And then I just got super sick and my lungs are still trying to rebound. So enough about me. We can start with. You're just, I'm sorry to say. Well, that's why I didn't start with her and started this way.
I'm Sharon Jones Farino.
Hi, Sharon Jones Farino.
Didn't you say Jones?
Yes.
Okay. So
Yes, maybe we're related.
I'm a Jones girl too.
Okay.
And I have, as I always say, I'm the lightweight here. I have mild COPD.
Okay. Thank you. We have someone joining us via Zoom, so we want to make sure he can see, Randy can see everyone as you all are sharing. Okay, your turn.
I'm Mike Todd. I had a single lung transplant a little over 9 years ago.
Wow. Thanks, Mike.
I am Celeste Harris, and I was in the rehab in 21. So I've been around a while, and I have COPD and a number of other things.
Thank you for sharing, Celeste. Doc, your turn.
Hi, I'm Doc Davis. I was diagnosed with COPD. I had the zipper valve procedure done, and I'm here to learn more about transplant and all of that.
Dodie Dosh, I'm his spouse, and I'm just along for the ride.
Important to have those spouses.
It's a great sport.
I'm Birgit Baldwin, and I've been to a class here before. I think this will be broken. I have mild COPD, but currently I'm battle ovarian cancer.
Oh,
So
wow.
I came here for strict.
Wow. Thanks for being here.
Hi, my name is Gwen. I have COPD. I stayed here from the rehab class. I had a triple bypass open heart surgery 3 years ago next month.
Congratulations.
Phyllis, you're up.
I'm Phillips too. I have interstitial lung disease and I have pulmonary artery hypertension with blood clots, and I just had a surgery a year ago and I'm now off oxygen.
Amen.
Yeah.
White Martin, and went through rehab here, both before and after. I am about 2.5 years out from a double lung transplant.
That's a good go.
For almost.
Thanks for
See, part of the reason, a big reason why I'm still alive.
And all these wonderful people like
Let's see how we'll do the staff last, if that's okay.
Hi, I'm Sandra, and I have pulmonary hypertension, and I've been in the pulmonary rehab for a while.
Thank you, Sandra.
I'm Steve. I had a double lung transplant 5.5 years ago.
5.5? Wow.
So we could hang out.
Very good.
History of interstitial lung disease with secondary pulmonary hypertension. I also received a double lung transplant in 2012. So this year will be 14 years for me.
Ooh.
Since 2011.
Wow, 15
So,
years. Yeah, thank you, Bella. Okay, now we're gonna go a little weird and go to Jane.
Here, I've been a respiratory therapist for about 27 years, but here 4. So
Thank you,
welcome.
Jamie.
I'm Holly. I'm one of the respiratory therapists and I've been in pulmonary rehab for 3 months.
See how for almost 3 years.
Thanks, Lou.
I'm Laura. I'm a respiratory therapist here. I've been here for almost 5 years. Here for you guys.
Thank you.
I am my name also Steve. Been here for 5 years.
Amanda.
I'm Amanda. I'm a Janky Jones, so I guess I do belong with the Jones. I married into it, but I feel connected to the Jones girls. I've been with pulmonary rehab for years, but with UC Health now for like 4. It's 5.
Excellent. More introductions about these two later, but we'll let them do a little brief one for us now, Rebecca.
Quite a few faces.
Thank you, Rebecca. Alan. Thanks, Alan. We didn't miss anybody, right? We're all good. Okay, great. We're going to be starting off with Rebecca, who, as she just said, social worker with lung transplant. She's been here for 8 years and does recognize many faces in here. And so we'll let Rebecca take over and then we will hear from Alan. I'll pop back up really quick and then Alan will share. Thanks, everybody.
Thank you.
Don't mind, I'm gonna put this right there in front of you, if you don't mind.
No,
Okay.
no.
Okay, thank you.
Hi, so I was originally asked by Jamie to kind of come talk about transplant and the different phases of transplant and kind of the emotions that come up through transplant and the anxiety that comes up through transplant. Sounds like we've got a few posts people. I know we have a few post people and a few people thinking about transplant, but I think a good place to start is just starting with when you have a chronic illness and you can't breathe. Most people have anxiety. That's not abnormal. There's nothing wrong with that. And for a lot of people, they find ways to cope with it and ways to coping skills that help them manage in their daily life. But then when we bring transplant on top of it, there's a lot of extra things that come with transplant. So you already have a chronic illness, you're already struggling to breathe, and then when you're having a major surgery, and we're asking you to give up a lot of independence so that you can have a caregiver. And what I find is a lot of times by the time that I see the patients during evaluations, we've already had to give up a lot of our independence and give up for a lot of people, whether that's work or being able to do their favorite hobbies. And there's a lot of grief that goes along with that. You grieve your loss of independence. You grieve the loss of what you thought retirement was going to look like. And then you come in for transplant and we say, well, now we're going to ask you to give up more independence for a short period of time. And sometimes we ask you to stop some of the coping skills that you have been utilizing because they're not always healthy. So sometimes patients might take benzos to help with anxiety, which is totally normal. They're prescribed for you. But for transplant, we don't always want you on them because they decrease your respiratory rate. So then we're taking things away that are helping the anxiety while also sometimes making anxiety worse. So we talk a lot about this throughout the transplant phase and how to help. And whether it's medications, therapy, things like that, you know, that's part of what we all talk about during our evaluation phase and transplant phase. But I think it's also really important just to acknowledge that those are very normal feelings. And those are feelings that some people are able to process on their own, and some people might need a little help, whether that's therapy or medications. And then as you get through the transplant phase, I'm sure some of our post patients can tell you how fun the high dose steroids are in the hospital. They don't tend to make the anxiety much better, but the nice part about that is that we have ways to treat it in the hospital. Whether it's medication or we have some super cool, we were just talking about using virtual reality to help with anxiety and distraction and mindfulness techniques, or using our music therapy team in the hospital. They're fantastic. I recommend to anyone, if you ever get admitted here, ask for music therapy. I can't speak highly enough about them. But that's too part of what my role is as your guys' social worker, is to help figure out how to best help you guys navigate this, how to best navigate the anxiety in the pre-phase, the hospital phase, and the post phase. I think for a lot of people, when you're on oxygen for so long and you fight so hard to get to the transplant, sometimes you forget that you still have to remember what you want to do with life after transplant and what those goals are. And so it's really important to kind of set goals for post-transplant and how you want to live life after transplant and what you want to get back to. So there's also then all the emotions that come up too with our donors. Lung and heart are donors that we don't have living donors. Somebody can't donate their lungs to you and survive. So then there is survivor's guilt that comes with that, and grief, and how we work through and navigate that as well. And that's, again, kind of part of what my role is too, is if we're struggling to kind of wrap our heads around new lungs and new donor, or new lungs in this new life, how to best help you guys and how to best navigate this. I like to teach a lot of mindfulness techniques in the hospital. Do any of my post patients remember? And I know I didn't teach, you were before my time. You two I'm looking at, but our OT uses a lot of.
She makes you feel old, doesn't she?
You before my time.
We've had some contact.
We have. But that's where too, sitting and looking at techniques, even for people who don't want transplant, how do you calm yourself down when you're anxious, and what works for you? And a lot of people like to say, we'll take deep breaths. It's not very easy when you're on oxygen. We like the breathing techniques. They're great. They don't work for everyone to bring that anxiety down. So there is some really cool techniques. How many of you guys are familiar with something called the 5, 4, 3, 2, 1? Okay, sounds like that's one that's been talked about. So what that is, and it's an easy one to do by yourself, which I really like. And it is when you find yourself getting anxious and kind of building up to that almost panic mode, finding a way to distract yourself. So it's name 5 things you can see in the room, 4 things that you can touch, 3 things that you can hear, 2 that you can smell, and 1 you can taste. Now, if you're in a room that you don't have food or things, you can change those up, what makes the most sense. But that distracts your brain and brings you back into the present. So it's really, really helpful when you find yourself getting worked up. The other one that I like to use a lot is sour candy. Super simple. You can, warheads, carry warheads with you. And if you find yourself getting a little bit stressed and anxious, that sour zap is sometimes enough to start to bring you out of that anxiety. But these are all the things too that, as you go through evaluation for lung transplant, we may say, hey, I think you should maybe go to some therapy to learn some coping skills, to learn how to be non-independent in the hospital, because I think the bed alarm is the number one complaint that I hear from most people is not being able to get up on your own to go to the bathroom, not being able to do those things. It's frustrating when you're used to being independent. So what do we do to kind of work through some of that before transplant? Because then when we put you on high dose steroids, when you're here in the hospital, we tend to make your anxiety worse. So the better we go into transplant mentally prepared, the better you're going to heal on the back end. Because you're not going to be in your head about the fear, the anxiety. And if you are, we have those coping skills to like lean on, rely on. So that is
What qualifies you for it?
That's a great question. It really just depends on kind of your medical conditions. And, you know, we do our evals are 5 days long. And so the big things are compliance and showing that you've been compliant with doctor's recommendations thus far. You need a support system who can stay with you for up to 3 months. And then besides that, during those 5 days, what we do is a bunch of tests. We look at your heart, we look at your blabs, and then kind of make a determination on if we think you're a candidate. If you're interested, what I would say is ask your doctor to refer you. And if anyone is interested in learning more about it, but not sure that that sounds like the right route for you, you can also ask your doctor to do a referral for an initial visit, just to talk with one of the palm transplant doctors and hear from their perspective what they think about your transplant candidacy.
Okay, also, has there been any rejections of a lung? Somebody else's lung going in somebody else's body? I mean, where the body rejected the lung and it just didn't work?
The rejection comes in different forms and layers. So most of our lung transplants have had some type of rejection that we can bring in and we can treat with steroids and other stuff. Very rarely do we see the immediate rejection.
Okay.
It happens, but most patients experience some type of level of rejection throughout their transplant.
Also, how do you see how I can say? Get a lung that's gonna match somebody's body. I mean, size.
Oh, you're gonna ask me all the medical questions.
Rebecca knows.
I
No, she knows it's fun. However, just in case, in 2 months, in May, Dr. McClafferty is gonna be here and he can also answer all the medical ones.
Okay.
She can answer some.
Yeah. No, but that's a great too. I think for a lot of people have heard the word transplant, but don't know what are my next steps. Is it something that I can do? And we are the only center in Colorado that does lung transplants. So we love our community pulmonologists. They're fantastic. What they know about transplant is not always up to date. And so sometimes some of our patients don't always get referred and need to advocate for a referral, which is I highly recommend. And we'll look at your medical records, our medical director, Dr. Gray will, and if we think that there is nothing in your records that say, oh, we shouldn't do this, then we'd bring you in for an eval.
The patient guaranteed pretty much not to be on oxygen after a transplant?
No.
Okay.
There's varying degrees of results, all the way from people who don't survive the surgery to I have patients that are out climbing mean 14ers and Machu Picchu. So it very much is dependent on how your body responds to the meds and the surgery and all of those things as well. But you can imagine talking about all that and looking at a surgery where I just told you that I have patients who don't survive.
All right.
That's going to cause anxiety for people.
You changed their mind.
Yeah, and I say when you come for an evaluation, you're evaluating us as much as we're evaluating you guys. This is not the right option for everybody, and that's okay. And if it does seem like the right option, great, and we proceed forward. I think you have some fellow group members who would speak highly about their experiences. And I do have some flyers for our mentorship program. If you guys are interested, for my post patients who are here, if you are interested in being mentors, also come find me. But we go through the National Lung Foundation. They help us manage our mentorship group because the two women who run it have had lung transplants. So I could sit here and talk to you guys all day about lung transplant. I find it fascinating. I think the different things to working up to transplant, to getting your life back is all fascinating. But I've never sat where you guys are sitting, and I want you to have the ability to talk to people who have. And I will say, we don't cherry pick our mentors, so it is not all patients who've had really good experiences. It's patients who have had a transplant and all degrees of experience. Lung transplant's not something we sugarcoat. It's not easy.
I want to mention something about the Lung Transplant Foundation. They can provide mentors for people that are thinking about it.
Yep.
Waiting list, after, and up to a point, Rachel helped me, I think, also for care providers. I think they've got a program for that.
They do. Right now, I only have one caregiver trained, but I am working on, we are working on expanding our mentorship group. Because I do think it is important for you, even in the post-transplant phase. I have some patients who have been transplanted and really struggled to wrap their head around what's next. How do I honor my donor? And having somebody who has been there and walked through it is a great way to help as well. So, and I think coming to these Better Breathers clubs more than not, when I say, hey, let's get you a mentor, I have patients say, oh, I know a bunch of lung transplant patients. I'm in Pullman rehab, because you get to learn about their experiences. But I think Jamie and I were talking a lot about, I think there's a lot of unrealized grief, guilt, anxiety that comes in every phase of having a chronic illness, whether it's transplant or not. And how do we navigate that and help patients and help them get healthy to whatever level that and comfort level that they are hoping to get to. Any of my people who've had transplants want to talk about their experience of anxiety, emotions that you didn't see coming, things that popped up after? And I'm not putting you on, oh.
It'll be 4 years in September. And I went through a period because I was older when I was 75 and on the brink. And my donor was in her 20s. And I went through a period of really mourning her and like, did I deserve this? At this age, I was afraid to tell. When I wrote my letter to her family, I was afraid to tell them how old I was. You know, I put myself in their shoes. It took me a while to get through that.
Did you find writing the letter helpful to help get through it?
I did, but I never received any response or anything.
Oh.
But yeah, I thought that's something that we didn't anticipate thinking about.
Absolutely. That's a good one that a lot of people don't think about.
I would say for myself also, that was something that I did not anticipate with survivor's guilt. Especially because for me, before the transplant, I was actually in the ICU for about a month and a half, almost 2 months. Prior to my transplant, I was that sick. And so the whole time you're sitting there they're like, oh, I hope I get a set of lungs, but on the other hand, they're like, well, it's almost like you're hoping for someone to pass, right?
Yeah.
So there's that guilt. And what actually helped me was someone had said something to me, and I don't remember the exact words, but it actually gave me some relief because they told me they would pass regardless, right? But think about it. They made the choice to be a donor, and you are literally filling their last dying wish.
And I also say to a lot of patients too, who have those same thoughts of, it is very rare that in death, somebody's family gets a silver lining. And this is a silver lining. This is their loved one is able to continue helping people even in their death. So I know that's heavy to think about, and everybody has to process in their own way, but very true. Donors are going to pass no matter what. And this is actually a really great gift from them and for the families to get to know that their loved ones are helping people. So you're
As far as like, just kind of, being unsure of everything, it's kind of making the right decision on we have to end the operating meeting. It's the right thing. Of course, it's too late, you're there, but as far as like, I didn't have any guilt. I felt grateful, but I never felt any guilt. Bella said that person would have passed away anyway. It's being grateful for the gift they gave me. No guilt.
I'm gonna put you on the spot a little, but I'm not sharing your personal info. Steve is a great example of somebody who worked very, very hard to get to transplant. You got very, very sick, and we give patients a lot of homework. And so we sometimes give patients lists of 5, 10, 15 things that needs to happen before we can get them transplanted. But those things are all what helps you prepare and be the most successful with transplant as possible. And I use your story as an example quite a bit because you definitely left a mark on how hard you work to get there.
Oh, oh, wow.
Yeah. I would assume all of my post patients would say it's not an easy road or an easy recovery, but what you get out of it can be very beneficial for a lot of patients.
Steve, was that before the transplant?
Didn't mean to put you on the
No,
spot,
you're good.
but I
That was a problem.
you were impressive. You will always say,
Rachel, I gotta throw this in.
Rebecca.
All of the transplants are not, they're all serious. But some of them aren't as bad as what you hear.
Yes.
And I'm gonna brag, because I had very little to do with it. I walked into the front door of UC Health on a Thursday morning, about 9 o'clock. They didn't operate until about 10:30 Thursday night to put in a single lung. 7 days later, I was sitting home on my couch with no oxygen. That's the good side or the happy side of it. And I've had things happen since,
Absolutely.
but I also figure I had two things going for me. I had a 20-year-old donor, and I had one of the best thoracic surgeons in this part of the country, and he remembered which hose went to where.
Yeah, and when Dr. McLafferty comes, you
that's
guys will
important.
love hearing from him. He has the best analogies out of all of our doctors, and he is a phenomenal teacher. So he will be great with Dr. McLafferty. He'll be great about the medical side of transplant as well. And that's kind of the cool part. You get an interdisciplinary team that follows you for the rest of your life. So while I don't have a ton of interaction with some of my post patients because they don't need social work, I'm always here.
And as far as like city team, like I've been in the hospital, I need replacement, two other things, still lung transplant, comes around, checks on you, even though it's not a lung issue. You come along to their property, they look out for you.
Yeah, we're very possessive of our patients. But it's a good thing.
It's great.
Are there other questions I can answer for you guys?
A quick one.
Yeah.
Hypoxic, is that a firm no? You're not qualified or
No.
a transplant?
Oh, yeah, it's actually interesting. So part of our transplant, the very first part is they come see Jamie at pulmonary rehab, and she tells us if you're using the right amount of oxygen or not. So a lot of our patients come in hypoxic. A lot of our patients might even have some memory and cognitive stuff because they've been hypoxic for so long. But that's where throughout evaluation, we figure out what oxygen levels you need and what makes the most sense. And then if we tell you you're supposed to be on 10 liters of oxygen and you choose not to wear 10 liters of oxygen, then we get into compliance stuff. But no, hypoxia is really normal, and doesn't preclude you from transplant, at all. And you know, I say we see patients kind of in 4 different phases. So some of our patients come in on no oxygen at all and are super early and want to get the information and learn about it. Some of our patients are what I call in their window, so sick enough but not too sick, but maybe have some homework if they do, like some working on caregiver, getting stronger, getting in pulmonary rehab, maybe some mental health therapy. Other patients come in through the hospital and it's an emergent situation and we got to figure out the evaluation and transplant really quickly. And unfortunately, some of our patients come in too late and have missed their window and transplant might not be an option. But at least you know that, and then we can look at what the best next steps are.
One more thing, how do you know if you need a single or a double?
Great question. Diagnosis. So whatever your lung disease is, there are some that we can do single, there's some that we won't. And age, over 65, we tend to like to do singles if we can because it is an easier surgery. Most of our patients are in the hospital with us 2 to 3 weeks. So he just said 7 days. That is a very short, even for a single lung transplant. Yeah, 7 weeks. Yeah, so everybody's experience very much varies. But our surgeons and our doctors will kind of decide single versus double.
So you said over 60.
65.
65.
Okay. And we transplant up to 75 now. Well, we transplant up into the 70s. We don't have a firm cutoff.
Okay. A quickie.
Yeah.
Is the swallow valve part of the routine pre-testing to rule out aspiration?
That's a great question too. It is now, yes, for most patients. We do have a lot of patients who have some swallowing issues post-transplant. The way we do the surgery, we sometimes stretch out the nerve. You also get intubated during surgery, what can cause. So we do swallow pre and then in the hospital before we let you eat now too.
Something that was really special for us is that, well, Dwight did pulmonary rehab outside of UC Health, but then when got the referral for lung transplant, came here, and I can remember Jamie saying at that point, Dwight was on, how many liters were you on them? 8 to 12 when he came in here, and Jamie smiles and says, okay, there's, if you need more oxygen, we'll get you more oxygen, and just emphasize, you know, we need to keep your heart healthy, we need to keep you moving, and we said, well, okay, here we go, and the oxygen was there and on the treadmill he went and we dragged oxygen everywhere. I mean, we had a wagon. Dwight helped our daughter build a chicken coop in their backyard. We put the O2 compressor in the wagon, wheeled it to the backyard. I kind of made sure I was sort of in control of making sure that, you know, we were okay while he worked away, but that was just very encouraging because it's scary to exercise when you're needing all this oxygen. And she just you just
Well, and everybody here was so supportive, but it was very encouraging to hear, okay, we didn't need to be as fearful. I mean, a lot of that pre-transplant journey was managing that oxygen.
Same summer of 23, we went to visit our daughter family up in Craig and, loaded up, of course, the concentrator and about 30 eating. Yeah.
Oh, well, it's not in your car.
Maybe should have had a yellow placard on the back window, but anyway, yeah, if we would have been rear-ended, we would have a quick shot of that. Thankfully, made it there and back.
Yeah, and I think too, I mean, it's great. I think Dr. Gray, who's our medical director, came in the same time I did. We started about a month apart. So we've both of us been here 8 years, and she really has integrated pulm rehab into our evals because you guys have a specialty that really helps us. PT, making sure that you guys are strong enough. If you've got osteoporosis or you're weak, you're probably not going to heal very well from the surgery. So we want to treat those things before surgery. But that's where we've turned our eval from what used to be 3 days to 5 because we have so many people with so many different specialties looking at every aspect to try and make this as successful as possible, and to try and just help wrap your head around what's coming up or what has happened and come up, and help ease some of that.
So your hospital stay is usually 7 weeks?
No, we tell most patients it's between 2 to 4. Some patients are here 7.
Some are troublemakers.
Again, it can be a spectrum completely depending on how your body feels. I've had patients who've been here a year in the hospital. And I have had patients, I think the record is 5 days now. I think it might have.
But I
was like, that's the one I heard most recently. For a double, it was 5 days, but, those are the things that you got to have some grit, is what Dr. Gray will always say, and motivation. And that's where you've got social work site and your medical team helping to make sure that we are getting you guys through as best as possible and treating the mind and the body.
So how do you do this? Go through the front or the back?
That's a great question. For a double, we do what is called a clamshell. Dr. McLafferty, who you will meet, lovingly describes it as cracking open a car hood. So like this. Some of our surgeons on a single don't crack the sternum and will go in the side. Depends on surgeon, depends on body type, depends on what surgeon's doing it, what technique they use, all of that.
Regardless, you're gonna come out looking like Frankenstein.
Yeah. Like Frankenstein. Lots of different scars and marks.
Not a scar, armpit, armpit.
Yeah, that is the thing that I think I was most amazed about when I started, is actually how good the wounds heal and the scars can look. For some people. But yeah, I would highly encourage, if you guys are interested in learning more, talking to your pulmonologist and having them send out a referral. We can always look at medical records. You can always come in for an initial visit and meet the medical team. If we identify from medical records that maybe there is some need for some social support too, I will get involved at that point to kind of help look at caregiver, social support, finances, mental health, all the non-medical stuff comes to me.
Sounds
Rachel,
good. Excellent.
When I was finally accepted and put on the list, the hospital gave me a huge 3-ring binder that had everything that what was going to happen up until the time you were accepted. It walked you through all of the stuff that would happen in the hospital. It gave a list of drugs and the side effects and why they were there. And it was an incredibly wonderful thing. And for me, it made me feel a little more comfortable going into it. I don't know if they're still doing that.
We do. It is currently being worked on to update, so it's a little outdated, but we do. It's been updated since you got it, but we do. We have a full binder we give you guys, and part of what we talk about is just bringing back to a little bit of kind of what my role is. Two is some of the advanced directives, who's going to be your decision maker, and how you prepare somebody to have to make some decisions for you. So yeah, no, we give out that binder. We also now do an hour-long class every Wednesday for all of our evals. So I think as a team, we work really hard to make sure you guys have a very reasonable expectation going in. That being said, we don't know what's going to happen, and so we try our best to prepare you for everything we can.
That was great. One more, we're going to take one more question and then we're going to move on to Alan. Go ahead, Sandy.
We hit 1,000 lung transplants this summer. We do about 50 a year, a little less than 50 a year. But yeah, we've done 1,000 lungs, 1,000 hearts, and as a whole transplant center, we hit 10,000 this year.
Oh, cool. That's awesome.
Busy place. I will mentorship things on the table. Like I said, if any of my post patients are interested, they can also apply to be mentors. And let me know if you guys need anything from me.
Sounds like we'll probably need to have Rebecca back. What do you guys think?
Thank you. Appreciate it. Thank you, Rebecca. That was a wealth of knowledge. Are there any resources, you talked about emotional impacts that come along with any chronic condition? Are there any resources that you can share about mental health tools or techniques that maybe you can send to Jamie and we can disseminate for the group?
Yeah, that's a great idea to do, and I will
Thank you.
Get that together.
Yeah. Thank you. Thank you again, Rebecca.
Yeah.
That is great. Okay, next up, I felt to mention a couple of things. With two speakers, we're probably going to go a little bit longer today, so past 1:30.
You can take as long as you want, Alan.
Yes, not on the clock. Just carry that for the rest of you. The bathroom guard, the snacks. I didn't mention that. I'll pass around the evals if there's anybody who didn't get it. Once Alan finishes. If you didn't sign up on the sign up sheet, it is over there. I think most of you grabbed it when you first walked in. Let me introduce Mr. Allen Wentworth. I have to personally say, outside of the staff here at Home Rehab, he is one of my favorite people that I've met through this asthma and trying to keep living.
Sorry, Jessica. No, just the TV.
I should stay girl. From moving mountains to air filter giveaways, and this is an amazing fella. He was the director of respiratory and home rehab here for 16 years, 18, 16, 16 years. Currently sells medical equipment. He's the board chair for the American Lung Association, which is where Better Breathers Club is run out of. He got the Volunteer of the Year award at the gala. For those of you who were here last month, I told you I was going to the ALA gala. He got the Volunteer of the Year award. Super exciting. Just gives you an idea of the caliber of the man who is about to talk with us. He's also talking about one of my favorite topics, which is air quality. After hearing Alan speak, I don't leave my house without checking my phone to see what the air quality is like, to see if I should be leaving my house. So anyway, I hope you all enjoy him as much as I do. Thank you.
Appreciate it.
Okay. Ready.
Awesome. Thank you very much. Welcome, everybody. I love to see caregivers here too. You guys are such an important role for your loved ones. And we actually have a caregivers network. Our Moving Moms Conference, not this year, but hopefully the following year, we'll actually have a caregiver breakout session for those that want to go in and talk about caregiver issues and challenges and maybe how we can better help you. And so forth. There's support groups for caregivers as well. But nevertheless, I'm very informal with my presentation. So if you have questions, speak up. You can wait till the end, or you can ask me during, or if you don't want to speak up, just let Jamie or Alex or whomever, there's so many people here, just let them know what the question is and they'll email me and we'll get it answered for you. Okay. Sometimes people don't like to raise their hand and speak up. So first off, did any of you see me do a presentation here last year on the state of the air? Okay. I am going to apologize right now. I thought the new state of the air data was coming out March 22nd. When I went to update my PowerPoint presentation this weekend, I saw it's not coming out till April 22nd. But that's not necessarily the goal of this presentation. The goal of this presentation is to help you understand how to better protect yourselves from the air quality that you get exposed to. Okay. And I also am going to run through a little bit on our website, lung.org. One of the things we do is we actually have all kinds of resources on there that a lot of people don't know about. We have a lung health committee with providers on it, pulmonologists, APPs. Bella's our patient rep on there. We have pharmacists, PTs, exercise physiologists. We have a psychologist, a PhD prepared psychologist. We have a whole interdisciplinary group that tries to look at issues going on in the state of Colorado regarding lung health and what can we do to better improve that. And one of the things we're going to be focusing on this year is trying to create support groups out in rural Colorado on the western slope, down south, out on the eastern plains, and try and see if there are a few remote programs out there. I understand you guys are starting to look at a remote program. And I think that's so important because the patients that are in a metro or an urban area, they just don't have access. And I think every one of you here would sing praises for what you got out of pulmonary rehab. That's what I hear frequently anyway. So let's move on with this presentation. Oops. Too fast. There we go. So nearly half of the US population right now lives in unhealthy air quality. And you know what? They're rolling back all the EPA guidelines and everything going on, and you see our climate change, and you see the dryness, and you see our reservoirs are down to nothing, and our rivers are bad. You think we're going to see more fires this year? We're already seeing them. It's not going to be good. So I think it's important to understand how to protect yourselves, and not just you, everybody. Okay, people that even don't have lung disease. So a couple of things I'm going to run through is this is an app called airnow.gov. How many of you have smartphones? Good. Yes. So smartphones are one of the things that make me feel dumb. But nevertheless, I think if you pull up under apps, airnow.gov, that is an awesome resource for you to check the air quality. And the data that comes from this is all the EPA monitors throughout the country. There's over 5,000 of them throughout the country, and it's constantly monitoring two things. One of them is ozone in the air, which you'll see here that Denver is the sixth most polluted city in the US regarding ozone. And it'll also monitor particulate matter, which are little aerosols, little particulate matter, if you will, that you see when we have fires come around, okay? And the beauty with this one that I really like is this thing.
You look at the news apps and the news, and they'll tell you what the air quality is today, but they don't really project what the air quality is tomorrow. Okay, they don't really, they could actually get this app and find that out. But nevertheless, you might be planning a picnic in the park, okay, the next day or whatever. So look at the air quality and see what it is to help you determine, do I need a mask? Do we need to cancel? Do we need to move indoors? Whatever the case is. How many of you have already heard about airnow.gov? Good. How many of you had it loaded on your phone? Good. I really, really think it's an extremely valuable tool. I can tell you that I myself am an asthmatic. I've been an asthmatic my whole life. So I watch this. I can pretty much tell when ozone levels are up just by the way I feel. But I'll go ahead and look at this anyway to validate where I am. And I'm now at that stage to where I was that kid that had asthma, I lived on a farm. My triggers were wheat dust and alfalfa. I threw hay all the time. I harvested every year. It's amazing I'm still alive today because during harvest, this was back in the 70s, okay? And we didn't know what we did, and I lived in rural Kansas, and all I had was Primatene mist. I would go through a Primatene mist every 2 to 3 days, which was horrible, horrible. But never, and then I'd go home, and my parents didn't know any better, but I'd go home to a father that smoked 3 to 4 packs a day, my mom that smoked 2 packs a day. I had pneumonia 6 times in my life as a kid. I had acute bronchitis at least once every year as a kid. And, they didn't mean to do anything. But nevertheless, because of all my infections and everything that's gone on and my exposures, I am now moving into what they call asthma COPD overlap. So I am now mild COPD, never smoked in my life. I'm exposed to tons of secondhand smoke. But did you know that 1 out of every 4 patients diagnosed with COPD never smoked?
People who have COPD then have never
Yeah.
smoked.
Probably lots of significant secondhand.
Can you get it?
Yeah.
Yeah.
I can't remember a Christmas Eve at our house, sitting there around the tree opening presents where it didn't look like a pool hall. And I gotta say, when I finally moved out and went to college, it's like, holy smokes, I can breathe. This is much better now, but nevertheless, so I really do live by this app. I love it, and I encourage everybody to do so. When you look at this app, here's a little bit of data. If it's in the green, between 0 and 50, everybody's healthy, everybody's fine. So that's a good thing. If it's in the yellow, that's when you that have, lung disease might want to start to be a little bit cautious about going out, minimize your time outside, take those steps to protect yourself. When it gets into the orange, well, then you should avoid going outside. Okay. We were going to have an asthma walk on this campus about 3 years ago, and and it was going to be in the fall time. It was going to be in October, and 2 days before, guess what? We had to cancel it. Why? The air quality was horrible. That was just a stupid plan. Not a good idea to do it in the fall. You get on down to red, it's unhealthy for everybody, and you really need to stay away from going outside. Purple, everyone should consider staying indoors, and here everybody should shelter in place if it gets to the maroon. We are seeing more red and purple days as time goes by every year, just FYI. So that is a very important tool, this app, to help you stay protected. And again, like I said, we have over 5,000 active monitors in the US. So far, they're not looking at taking those monitors away. Those monitors are out there. And I hope those monitors don't go anywhere because a lot of you guys, a lot of people rely on that data to help them through their day. Okay. As I said, they monitor ozone, they monitor particulate matter. And I'm going to get into what ozone is here in just a second. So if you look at 125 million people, living counties in the US with F grades for ozone, commonly referred to as smog. Okay. It's interesting because in the wintertime, do you see more of a brown cloud than you do in the summertime? You do, but that's not necessarily ozone. That's a lot of other factors that come into place. Car exhaust and whatnot, which goes into particulate matter. But the whole thing when you're making ozone, sure, you have that exhaust, but then we combine it with heat. That's when things turn into ozone. And that's why you don't see those issues in the wintertime, even though the quality of air looks horrible. Yeah, it's just kind of gross. So what is ozone and how does it form? Ozone is actually 3 molecules of oxygen put together. Who cares? It will aggressively attack lung tissue, lead you to bronchospasm, shortness of breath, inflammation, those kinds of things. And when present, other harmful pollutants are also created. Ozone is formed by the nitrogen oxides, like nitric oxide, nitrogen dioxide, from exhaust, from any kind of combustion of fuels, from fires, whatever the case is. And then it combines with things we call volatile organic compounds. This sounds like voodoo stuff, doesn't it? There's volatile organic compounds in everybody's home. There's volatile organic compounds right here with the adhesive that holds this carpet down. But it's not really a problem too much unless it starts to combine with the nitrogen oxides, okay? When you combine those together and you add heat, like it's showing here, then you have ozone that forms. Does anyone have any questions on ozone? Sometimes people will say, they talk about ozone. High-level ozone is not bad. If there's ozone up in the sky, as a matter of fact, some of the reasons that the sky, when there's no clouds, is blue is because of ozone. Okay, so that's why you see that. That's not a bad problem. Ozone on the ground level that we breathe in, that's where the problem is, okay? So, again, this is last year's data, but you can see if you're looking at cities, Denver, Aurora, and Greeley, that whole area right there, is the 6th most polluted city in the US. And these are all around LA. Phoenix, have any of you been to Phoenix lately?
Yes.
They have a brown cloud that's pretty bad too. But here we are, number 6. Anticipating that, so we've been number 6 for the last 3 years. Prior to that, we were number 8. The year prior to that, we were number 10. So it's getting worse. We've held steady and speculating it's going to stay steady and we'll probably still be number 6. But nevertheless, we'll see when that data comes out. When that data comes out, I'll just do a quick little flyer and send it to Jamie so you guys can see it. Okay, looking at different counties that are bad. These are counties that are on the Front Range close to you guys that all have F grades for ozone. And again, remember, this is primarily a summer thing. However, was this a crazy winter?
We didn't have one.
No, we didn't have one. Yeah, and actually there were some days where we had a little bit of ozone problem. Not bad like you see in the summer, but nevertheless, just something to think about. Another thing is Fort Collins is number 13 in terms of the most polluted city. Does that surprise anybody? A lot of it here has to do with ozone not clearing out because of winds and the way the air flows over the mountains and everything, and it just kind of circles around a little bit. Like you see a river going, water going around a pebble in the stream. You see the little swirls afterwards. That's where those fly fish hang out. But nevertheless, so I think that's why we have problems. Colorado Springs is number 23. Anticipating Colorado Springs will bump up a little bit this year. So nevertheless, okay. So what happens when it's high ozone days? Well, you can get short of breath, have wheezing, exacerbations with your lung disease, higher risk of inflammation. And we see increased ED visits, increased visits to the doctor's office, hospital admissions can increase. Believe it or not, you can actually start to see some CNS changes a little bit and, cognitively, if it goes on and on. Last summer, we had high ozone days, I want to say for like 45 straight days in a row. It was one of the longest bouts we had had. And I don't know, if you start to feeling a little bit, a little bit off, that could be part of it. Okay. What do you do for ozone? Go ahead. Oh, central nervous system. Sorry. Thank you. And interrupt me with those things here. Yeah. So that's very important. How do you protect yourself from ozone? You can't. A mask won't do any good. It's a gas. Okay. Masks are only good for particulate matter. This is a gas. So all you can really do there. Oh. Everyone's ready for the floor to go, right? So you know, you can't wear a mask for it. All you can do is protect yourself, minimize your time outside. If it's like we said in the red and orange, or red and days, or maroon, for sure, stay inside. Okay. So sadly, we don't have a lot else we can do about that. One of the things, and the only way we're ever going to change some of this environmental stuff, is through advocacy and letting our elected officials know that we are very concerned about our air quality. Very concerned about our air quality. And we have ways for you guys to engage and do that if you want. The American Lung Association has action alerts and set some barcodes to you guys. Can you guys use QR codes on your phone? You know how to do that?
Yeah.
Okay, so you just put like you're taking a picture, you put it on the QR code, and then you'll see a little yellow thing pop up. Click on that, and it takes you to that site or that page. Okay. It's really fairly simple to do, and it does make things easy. You know what might be helpful is if you guys had instructions for how to use QR codes with your smartphone. Would that be helpful?
Yes.
Okay.
Or have a grandchild with.
Exactly. Not everybody has that. 100%. So the next thing I'm going to talk about is particulate matter. Okay. 77 million people live in counties with F grades for particulate matter. And this is the one we're really seeing change from all the fires, and not just the fires in the US, the fires in Canada and other places that start to drift around down into the US that causes problems. I mean, it was last week, the fires in Nebraska were actually coming into the Denver metro area along with dust and everything else, because it's such a calm city. There's no wind around here. But what is particulate matter? It's particles or little drops that are suspended in the air. You know, the MDIs that you take and your nebulizers that you might take, well, those are particulate matter, but those are particulate matter with healthy medications. And they have to be a specific size to deposit down in your airways. Okay. If they're too big, guess what? They're not going to go down in your airways. They're going to impact that little curtain that hangs in the back of your mouth, your uvula, your tongue, everywhere on the roof of your mouth and whatnot, and not actually get down to where they need to be. If they're too small, you'll breathe them in. They won't deposit anywhere on the airways, and they'll go right back out. Okay. The ideal particle size for that medication to be delivered to you is what we call 1 to 3 microns, smaller than the width of a strand of hair. Okay. But what we look for with these monitors and in that airnow.gov is 2.5 micron particulate matter. That's that particulate matter that will go down in your lungs, and then it will stick in your lungs. It'll deposit on those airways. It's not going to go back out. Will you have some on your uvula and your oropharynx and stuff? Yeah, you will. But nevertheless, this is what we're looking at, the 2.5. That's the bad one, okay? And if we look at what's going on here in the Denver metro area, as you can see, we are having more purple days as time goes by. This is 2004 to 24. You see that it's going up quite a bit, isn't it? So that's why we're speculating. We're going to see more particulate matter in our report this upcoming year, because this is the trend that's going on. Maroon days, interestingly enough, they kind of dropped a little bit, but we'll see what the data shows this year. And just so you know, this data that you look at, so right now we're in 26, so it's not going to look at 25. It's an aggregate of 2024, 2023, and 2022. It looks at a 3-year aggregate, and it takes a while for them to pull everything together and go through all the data with those smart people that know how to work with data to actually get it out there. And again, if you look at counties in Denver, these are the ones we see kind of on the front range. Some of these will bounce over to the western slope, but you kind of see where our grades are. We don't look that bad right now in particulate matter. But if it's all related to fires, you think it's going to get worse? Absolutely. Can you protect yourself on those days with high particulate matter? Yes, you can. Okay. But you need an N95 mask. Okay. A regular surgical mask is not going to filter out those particles. So they're going to go right through it and get into your lungs. Okay. Those N95 masks, those masks like people use during COVID and so forth, those will filter out that particulate matter so it doesn't get in your lungs. Okay. Now, how many of you think it's hard to breathe with those masks on?
Oh, yeah.
It is. Definitely is. You just need to slow down, be cautious of your breathing, take some deep breaths and exhale completely for a few times every now and then. But you can't get through it. And if you don't, and you're out there for an extended period of time, you might be able to feel better without that mask. But come the end of that day or a few days, the inflammation is going to hit and you're not going to feel good without the mask. Please.
We've been wearing them and Dwight checks his oxygen with those N95s and it's never low.
Yeah.
Is it?
We were inside, stores and.
Sure.
Yeah.
Sure.
Whatever.
And why is that? Right. And that's because oxygen is a gas like ozone, so it's not filtered out through that mask. So you should still be fine. Your rate might pick up a little bit if you're feeling a little short of breath and a little bit anxious because you're wearing that mask and you feel a little more resistance. But nevertheless, really recommend getting those N95 masks. Okay. I guess I'll leave that at that. So particulate matter kind of does the same thing, except things a little bit different. The same thing as ozone. The things you'll see different is you'll see some eye irritation, maybe some redness in your eyes from the particulate matter and everything. So dry around here sometimes in the summer, red eyes kind of come anyway. So lung and throat irritation, kind of a sore throat. Okay. Trouble breathing, shortness of breath, dyspnea, whatever. Higher incidence of lung cancer with lots of particulate matter and people that are exposed to it for prolonged period of times. Problems with babies at birth can lead to actual premature infants being born. Things you see just the same as you do with ozone, increased physician office visits, ED visits, admissions to the hospital, incidence of premature death, not just in lung patients, but cardiac patients, CHF patients and so forth. You'll see a higher incidence. I'm not talking 10% higher, I'm talking small numbers, but nevertheless, it's something to be looking out for. Okay. Some of the things that's interesting, and I'll show you where to find this on lund.org. The stuff that I find very interesting is you can go and you can look in every county in Colorado, and you can see what the total population is, those under 18, 65 and over, but you can also look at patients with asthma, patients with COPD, patients with lung cancer. So cardiovascular disease, pregnancy, poverty level. We see more problems with people lower poverty level, higher incidence of asthma and so forth, especially in kids and people of color. So this is some data you can look at. And I just want to caution you, when it comes to looking at COPD for sure, and I'll just stick with COPD, is you can probably double these numbers. And that might be the case for asthma and some of these other ones too. Why is that? Because of access to healthcare. People don't get diagnosed or they get misdiagnosed. I don't know how many times people have been told, oh, you have asthma or whatever. So they give them a little inhaler. Well, that might not do any good. It just may spend your money that you didn't need to spend when you could buy food. So nevertheless, I think these numbers are probably a little underreported. And this stuff comes from CDPHE, the Colorado Department of Public Health and Environment, our health department, pulls data based on diagnostic codes to help identify some of the diseases in there. And I find that very interesting. something that I want to talk about, well, we'll talk about this first. If you guys use your smartphone on this QR code, what it'll do is it'll pull that little yellow thing up below that, as you're taking a picture, click on that, and it'll populate something for you to where all you got to do is enter your first name, your last name, your address, phone number is optional. And what it will do then is it'll pull up your elected officials based on your address. And then you can there's already something drafted. There's already the language in there that's drafted. You can edit it if you want. And I think it's always good for you guys to edit something and say, I'm a patient that suffers from chronic lung disease, from COPD, from pulmonary fibrosis, post-transplant, whatever the case is. It's near and dear to my heart. But then you just click send down at the bottom and it automatically goes to those elected officials. And you'll get responses back from the elected officials saying, thank you for voicing your concerns. And again, this is the only way. I don't know what else to say. And it's just really challenging right now in general. But this is the only way we're going to impact air quality. I don't know what else to say or what else to do. So I really encourage you guys to take action on that. There's another, so Steve, the gentleman, I think he just left, he's on 45 liters a minute. Can you get that out of a concentrator? No, I was gonna ask, I'm certain he was on liquid oxygen, or if he was on a big H tank of oxygen, like the big oxygen tank over there, he wasn't going anywhere. He was sitting at home. And one of the problems is DME companies do not readily dispense liquid oxygen. And I know a lot of patients that need liquid oxygen to stay mobile because their liter flow is so high. So there's something called the SOAR Act, and I know that that's been posted here, right, Jamie? It's a SOAR Act. It's the Supplemental Oxygen Reform Act. And some of the things that are doing is they're changing the terminology. It's no longer called home oxygen because home oxygen let the DME companies say, oh, we just need to provide oxygen in the home. Well, if you never leave your home, what's your quality of life? It's horrible. So we're changing the name of it. And what it'll do is it will provide better reimbursement for those DME companies that are providing liquid oxygen to patients so that they won't lose a bunch of money providing liquid oxygen. Liquid oxygen costs a lot more for the DME companies, only because of the fact that they're driving around all the time, refilling those liquid reservoirs into the home. And we got fuel costs and everything else going on. So it's really important patients have access to liquid oxygen. And the other thing that we'll do is it will provide reimbursement for the DME companies to have a respiratory therapist go in your home. And I think that's key too. We see patients here that are on oxygen and they get their room air sat check. They get their, ambulatory, what they need while they're walking, liter flow, and then they go up to Leadville. Think it's the same? No. So do the DME companies get up there to do anything? Well, they don't have RTs. Drivers can't check your pulse ox. The patients rely on it. You're told to either go see your primary care when you get up there. It's not easy to get in that quick. Told to go to the emergency room. How many of you just like to pay ED bills? Pretty easy to do. It's crazy. So we'll have respiratory therapists be able to go in the home, make certain you're on what you need to be on, and you have the appropriate equipment to stay active and live your life, just to the best of your ability. And that's the goal for everybody in here, isn't it? So, yes.
Well, the current, not to get political, but the current administration is trying to start up coal plants again. That can't be good.
No, it's not. One of the things that you guys remember down in Colorado Springs, they had the coal burning plant right there, essentially in the center of Colorado Springs. The American Lung was very instrumental in getting that plant shut down. And it's no longer functioning. I don't know if you've been by there lately. All that stuff's gone. There's still coal, but it's in the Nixon plant that's way south of Colorado Springs. That's not in that metro area. And I can tell you that some of the data that was collected was around that area. We saw a higher prevalence of asthma in kids, and we saw significantly more school days lost. They were out of school. Learning challenges and everything else. We're waiting for a little while. Hopefully next year or so, they'll start to recollect that data and see the improvement. Okay, very important stuff. this is what I want to do. I want to walk you through, and I don't know if this link is active. I'm just going to bounce out of here real quick and not act like I can see. Oh, good. It did work. So one of the things I want to show you, this is lung.org. And I will send a little paper to Jamie and Alex for you guys to have. So you can actually log on if you want. It's very simple, lung.org. But as you log on, look at all this information that's up here. The key areas you want to look at is lung disease, okay, lung health and diseases. Quitting smoking also gets into vaping. And that's another thing that's nice for a respiratory therapist to go in the home, because you go in the home and you can smell little things and say, I thought nobody in this house smoked. Well, my grandson smokes in the garage. Well, that's not good. You can smell it in here. You're probably feeling some of that, and it's not healthy for you. I can't tell you the number of times I've been in homes, my parents' house for one, and went over to that old fashioned console kind of humidifier over in the corner, and you lift the lid and there's like fungus floating on the top. That's not good. That's not healthy for anyone. And patients really need to make certain you clean your spacers and your nebulizers. I remember going home one time and my dad's eyesight was not the best, and my mom was suffering from Alzheimer's. And going there and looking at him, it's like, oh my gosh, what's wrong with you? Listened to him. We went right to the ED. He had pneumonia. And I went home and I start to look and I grabbed his aero chamber, his little spacer, and he was taking nebs too in his nebulizer. And they were laid out on a towel by the sink, drying out, but he wasn't using soap. There was some slimy stuff in that spacer. And spacers, by the way, most of them you can put in the dishwasher. FYI, just so you know that, to help keep them clean. So there's those little things that I think are so important that a respiratory therapist can do to help. But if you look at this, let's look at some of these health and wellness about vaccines. That's very controversial this day and age. You know what? Ask your doctor, okay? Let your doctor know. I am a firm believer that you need to get the flu shot. You need to get the pneumococcal vaccine. I'm a firm believer. I have it. I had the RSV vaccine. There's all those different vaccines that you need to be aware of and need to have. Breathing exercises. If you need a refresher on diaphragmatic breathing, pursed lip breathing, other ways of breathing, that's in here too. Talks about how your lungs work and what happens with age. We all start to lose lung capacity once we get to a certain age, but people with lung disease lose it much quicker than those that are normal. Okay, and then you look at all the disease-specific stuff you can get into. There's some great information. I'll just click on one of them here real quick. It can get very extensive on everything they have, what you need to know if you're freshly diagnosed, so on and so forth. Warning signs, about COPD in general and some pathology. You guys get all this from Alex. But again, if you have people that are in rural America, or rural Colorado, that doesn't have access to pulmonary rehab, let them know about this source. A couple of docs from UC Health that are on that lung health committee I'm talking about. Dr. Sarah Jolly, she's a pulmonologist here, and Dr. Trevor Steinbach, he's a pulmonologist here. They were the ones that said, oh my gosh, they had no idea that lung.org was such an awesome resource for patients and physicians. And why is it good for physicians? Well, let me go back here and show you. Coming over here, well, I'm going to just go through this first. Here's all the stuff for quitting smoking. Hopefully you guys have all quit smoking. Nothing to be ashamed of. My dad started smoking in the Air Force. They were part of his rations. Didn't smoke before, didn't ever quit. At one point I told him, Dad, I can't beat your deathbed. I just can't do it if you don't quit. And then back in the 80s, all these tobacco papers came out showing the science that they put into cigarettes, put into tobacco to intentionally addict people. And once I started to read all of that, I mean, they got into it deep. That's why you couldn't have kept me away from his bedside. Very important stuff. And he passed in 2002, was on a ventilator 3 times the last year of his life. Just very sad. But other things that people want to quit smoking, there is a 1-800 number we have, 1-800-HELP-USA. And you can call that. And if you want to quit smoking, they'll say, great. They'll get you set up with counselors. They'll help you get your nicotine replacement patches, lozenges, help you get some Chantix, tell you where to go to get it. But not only that, they'll ask about your smoking history. And this is one of the big things we really are bad on in Colorado. When it comes to lung cancer screening in Colorado, we are the 48th to the worst state. Only 7% of all those patients eligible here in Colorado actually get screened. So if you know someone that just stopped smoking in the last 10 years, let them know about that. Tell them to ask their primary care docs. And primary care docs don't have the time to go through everything. How long a visit do you get with them? You sit down and talk for an hour over coffee? No, they got like 15, 20 minutes. You're out, you're out, you're out. So just actively advocate for yourself. Very important. And if you have teens that are smoking, some great things are there. And there's also stuff on vaping for your teens. It's not just steam that they're breathing, folks. There's a lot of toxins in it. It's not healthy for them. Okay. There's lots of stuff in here about clean air, which I think would be a great topic one of these times coming up. Indoor air quality, not just outdoor, indoor air quality. If outdoor air quality is bad, you think somebody gets indoors? Yeah. But there's a lot of other sources for bad indoor quality besides the outdoor air. So there's all kinds of interesting stuff in there. And this is some of the stuff that the providers were interested in. You can get on here and look at different research trials going on, clinical trials, and talk to your doc about it. Say, hey, I might be interested in this trial. Okay, go in and look at some of that stuff. There's a lot of different information. So here's where we have the state of lung cancer report that shows we are the 48th to the worst performing state in doing screenings. The state of the air report you find here, the state of tobacco control you'll find there. We're getting better with the state of tobacco control, but we still have flavors is just something we just can't break through. The state legislature 2 years ago passed to ban flavors, including menthol, but then it got vetoed by Governor Polis. So we'll wait till he's out of office and try it again. The tobacco industry is powerful, very powerful. They have lots of money. Yeah.
What state you're looking at.
Yeah.
So you can look up Colorado. So when you look up certain things like events, it's more personalized for you. And it'll show events that are specifically to Colorado, such as like how they have the gallery here, how they involved
right.
moving mountains, and also the air climber here. It also has other things on there. So what groups things like that.
So this is where you can find all the data. You just go and ask for your location, you enter the state, as that fellow is saying. And it's great. I want to try and wrap this up and be respectful of your time. There's just a lot of information on lung.org, and I really encourage you to go and explore. And you guys have access to some wonderful people that teach you stuff, but not everybody does. Send it to your friends, send it to your families, whatever else the case is. Okay. And I'm just going to end by stating we have an air climb coming up at Coors Field on April 25th. We're doing something, we tried to do it last year, but the National Office of American Lung wouldn't give us a place for patients to register. So when you registered, it looked like you had to raise $100. Is that a barrier? Yeah. Anyone like to raise money? No. No, not at all. So this year we have a patient team, and you have these flyers sitting over there on the desk with another QR code. Ask your pulm rehab staff to help you if you want to do it. It'll still say in there, raise 100.
It's going to be there. I'm sorry. Michael's going to be there.
Good. Awesome. Thank you. Thank you. So you can click on here, it'll say raise, but we're going to ignore it. Nobody is going to hold you guys accountable to raise anything. Okay. So if you click on here, what it is, it's not running up and down the stairs of Coors Field. It's going to the elevator, riding up to the concourse, walking around the concourse as a team, and then all kinds of educational stuff after you finish. So there will be booths there to talk. We'll have a pharmacist talking about the medications that you're on and giving you advice and so forth. We'll have people there doing pathology. We'll have a DME company there with all different kinds of oxygen delivery devices. So we'll have a breathing lung exhibit. I don't know if you guys have ever seen the breathing lung exhibit from the American Lung. We'll have it hooked up to a ventilator. There's a normal lung and then there's a lung. It's a smoker's lung. So we'll be ventilating those. And I'm hoping to get a light popcorn machine because everybody gets drawn to popcorn and they'll come, but nevertheless, cool. So please feel free to do this. I think it's a good time. It's always great to have you guys get together. Okay. So again, I guess they're passing them out. And I left some cards on the table over there. I'm always happy to help anybody. If you have any questions, September 12th this year, we're having our Moving Mountains Conference. I know Doc's been on our patient panel there, and Bella is actually co-chairs the committee with me. And there's a few of you guys that are on that committee. So Jamie is going to be a speaker this year. We have a doc talking about pulmonary hypertension. We're going to have a doc talking about asthma. There's just some really good talks this year. We have somebody doing a Medicare update. Always important information. And this guy wants to hang around all day long so people can ask him questions. And if we don't get those questions asked, we can have people write their questions on note cards and we'll email them to them to get the answers to those questions. Okay. And again, we're going to have an awesome patient panel. So I'm right at 2:00. I'm going to cut it.
I guess so.
Okay. Thank you all very much. If anyone has any questions, I'm happy to hang around and do whatever. Thank you very much. Very good. Thanks.